present here with our teams. About the last presentation, I have some things to say about Dr. Raj's presentation. Usually we do OCT about for the diabetic patients, whether they are having previous macular edema or not. And if there is no edema, then we start NSAID eye drops 2 weeks before the cataract surgery, and we continue at least up to 6 weeks. And if there is edema, then we previous to the surgery we give the anti-VEGF, and we try to make it as minimum as possible, the macular edema, and then we do the surgery, because as you do the surgery the edema will increase, and then we continue the anti-VEGF. Okay, thank you. So with my presentation is the cataract and macular hole. No financial interest involved. So challenge for both phaco and retina surgeon, because there may be pre-existing vitreomacular traction, subtle macular hole, post-phaco posterior vitreous detachment may worsen vitreomacular traction and create macular hole, and routine OCT before phaco, in fact now advocated by American Academy of Ophthalmology also, and maybe a better option to avoid embarrassment after surgery. So deciding factors are age of patient, grade of lens opacifications, ability to visualize retina and macula, and vitrectomy increases lens opacity progression, and gas tamponade further increases the risk of lens opacification. So this is the study which they are telling, after pars plana vitrectomy with gas tamponade, person with less than 50 years of age, cataract progression is not much significant, over few years even. But in persons over 50 years of age, the cataract progression is significant. So in elderly patient above 50 years with visually insignificant cataract also, they may go for phaco with simultaneous or prior to macular hole surgery. So that may help them to avoid another surgery. Causes of cataract post pars plana vitrectomy. There are 4 theories: the ionic composition of the infusion, temperature of the infusion, microscope light toxicity, increased posterior lens capsule permeability. And the subject of phaco prior to macular hole surgery, more complete vitreous removal possible if we operate for phaco before the macular hole, and larger gas bubbles for a bigger hole possible. Post pars plana vitrectomy phaco may be more difficult, in fact, due to the increased anterior depth, genular weakness, and no anterivitreous support. And post-operative CME may reopen the previously closed hole also. Timing of phaco. In USA, they routinely do 2 to 3 weeks prior to macular hole surgery, but in all other parts of the world, combined phaco-vitrectomy is the preferred method. It decreases the number of surgeries, and minimum corneal edema should not be there, that we should see. That may create problem with ILM peel. Temporal section, hydration, and paracentesis better be avoided, and it leads to quick rehabilitation. Here we can see one of the surgeries where, without assessing much about the lens opacity, it went for macular hole surgery, and you see the vision is not very clear with the view. So after putting BB dye and trying with the ILM, ultimately we went for the cataract surgery and put a lens. And put sutures, of course, and then you see the view becomes much clearer, and the normal way we could have peeled the ILM, for which we are struggling at the first instance. Which one? Yeah. It is the previously operated eye for the retinal detachment basically. আপনাদের পাওয়ার পয়েন্ট রেসপন্ড করছে না। Silicone hydrophobic IOL, there will be fogging during surgery, contraindicated in silicone oil tamponade situations also. Mike? Yeah. So, actually, hydrophilic IOL opacification risks are there. Multifocal lens, absolutely no, because visualization may become very difficult in retinal surgeries. So, there is one normal pseudophakic eye surgeries. You can see with the clear media how can it be a good surgery, because for macular hole surgery we need excellent visualization. That is the first and foremost thing. So for that, if we have to operate the cataract, if it is a insignificant also, then also we should go ahead. So here you can see that's a normal way which we do. And then we did a reverse flap technique here. We cut all around and trim it, and then with fluid exchange time we just put the soft tip cannula the way so that the flap gets inside the macular hole without touching the whole base. And that was the result. There is one other traumatic macular hole surgery which you can see here. The papillomacular bandal area almost destroyed, and you can see the macular hole here, which we operate from the healthy retina. You can separate the ILM, and I put that ILM back to the whole base. And this is a Fenesi loop, just coaxing and cajoling the ILM over the hole, and then we do the fluid exchange. And this is the result. And the OCT, you can see it is closed, the V-shaped closing. Thank you. These are the references. Thanks. Yeah, little bit of cataract, better to do the surgery first, because otherwise after particularly our elderly people, they will anyway will need the IOL surgery later on. Better we do. No, that we don't do.
How long do you, usually in how many years do you see that cataract has developed after surgery?
The young patient I have seen even after 4 or 5 years also, they don't have much cataract progression. Like elderly patients, the more they are elder, the cataract progression is faster in fact. And we cannot tell with very firm convictions, but this fellow will have increased cataract and this fellow will not have.
But generally we counsel them like require a cataract surgery sooner than later actually.
Otherwise, if you don't do the first surgery I showed you, there is already a cataract done, and then went for that macular hole and see the problem. Thank you.
Thanks, Dr. Abhijit, for your